Good day, everyone. Thank you for joining us. Welcome to today's webinar, 5 Best Practices of Revenue Cycle Analytics and Denials Management. My name is Russell Hendrickson. I'm the President and CEO of Practical Data Solutions, and I'm really pleased to have joining me today Dan Marino, who's the Managing Partner at Lumina Health Partners.
Thank you, Russell. Really happy to be here and happy to share the stage with you again. We've done this a few times before, most notably, what, about 12, 15 years ago? A long time.
I was going to say, it's been a long time since we spoke together, and I think the last couple times we did it, we were doing it in person, but hey, technology and times. I noticed you seem to have found the trend I did, where gray is a little better than it used to be a few years ago.
Yeah, absolutely. Maybe it adds to the wisdom, not sure, or at least the mystique. Who knows?
One or the other, right? Yeah. So let's kick in and talk just a little bit. So I'd like to start out and just talk about visual analytics real quickly here. And what you're seeing on the screen is an example of a visual dashboard, and just about every organization, health system, healthcare analyst, is working with the technology today. It's pretty easy today to build visual dashboards, assemble a bunch of metrics. We're going to talk about denials and revenue cycle. And, so is it about the dashboard? Is it about putting some numbers on a page? No, of course not, right? So what we're going to talk about today, and, one of our goals is how do we take, reporting and dashboards and turn it into useful information? How do we use this information to identify problems and challenges and then work towards performance improvement? And so with that, Dan, why don't you talk just for a minute about what's going on in healthcare?
Yeah, as most of us realize, we're in a challenging time, and we have been for at least the last number of years. And as we moved out of 2021 and into 2022, we spent quite a bit of time, Russell, talking with a number of leaders across the country in hospitals and health systems and large medical groups. And there were some real key trends that emerged as we were starting to kind of gather some of our information. It was everything from building and rebuilding our operating margins to what our care delivery model needs to look like, certainly the growth of risk-based contracts, and then even the commitment to leadership development. But as we were talking, 3 key trends really emerged as sort of the top of mind issues. It was one, how do we get our margins, our operating margins back to pre-COVID levels? And it's a challenge, right? Because our revenues are somewhat fixed, costs are going up, certainly in today's world with inflation and some of the economic challenges that we have. It is really taking a hit on operating margins. So many of the finance leaders are asking the question, how do we get back to that pre-COVID level? And then number 6 that I've highlighted here is really pursuing what we're calling operational effectiveness. So it's a way of taking costs out of your operations without reducing staff. We can't reduce staff. Actually, many hospitals and health systems are trying to recruit staff. So we're not going to reduce, but what we need to do is create efficiencies in our operations that lead us to take costs out. The big challenge, though, for leaders is they don't know where to start, and they don't understand how they can create some operational efficiencies without really looking at the data and translating that data into real insights that allow them to make a difference. And then the third one that I would highlight is the focus on medical groups. We're still seeing that trend of more and more medical groups, more and more physician practices becoming employed. And there's a significant amount of investment that hospitals and health systems are providing or investing into these groups. So it's really increasing the loss per se of managing and how these medical groups perform. So again, leaders are saying, look, medical groups, alignment with our providers, it's ultimately important. It drives a lot of our care delivery. How do we make ourselves more efficient? How do we improve that bottom line? So those seem to be the kind of the top 3 trends out of the 10 that we're seeing, that if we can really start to talk about how data, how processes, how insights, how real change management can impact their ability to make a difference in these areas, I think that's how we're really going to help organizations right-size themselves going forward.
Yeah, we continue to see, when I talk to different organizations that you mentioned medical group management focus, just about every single one of our customers is either merging blending or, purchasing physician organizations. They're still, as you mentioned, coming off of COVID, still somewhat impacted by COVID, even in how they can see patients, so that operational area. And then, of course, technology, being an analytics company, we certainly see people looking to technology to help with all of these areas. And we're going to talk more about that as we go through the webinar today.
So Russell, when we start to think about what's going to drive a lot of the performance, you can't help but think that revenue cycle and our efficiencies in revenue cycle is really going to drive top line revenue, but it's also going to impact our cost structure. It's going to impact our contracts. It's going to impact our care delivery components. And a lot of times organizations aren't really sure where to start. So if you take an example and we look at, let's say, denials within the revenue cycle process, denials not only impact your ability to collect and to collect timely, if you will, but it impacts your value-based care contracts. It impacts your ability to reconcile. It impacts your ability to get good data to manage the populations. It impacts your patient experience. So a lot of these elements have many different trickle-down effects, if you will, that really impact the organization. And even beyond the organization, it impacts your physicians, it impacts your patients, and so forth. By having or helping organizations focus on where to start and really looking at sort of those root causes helps them think about how we can then put in place different solutions and really drive to results.
Yeah, and you mentioned patient experience. It's an area we talk to quite a bit, right? You can take a good patient experience in the clinic, and then suddenly you have all kinds of denials issues, or the patient may be responsible for something they didn't think they were, and suddenly their experience of their quality of care really changes dramatically when they suddenly get a bill in the mail that they thought was covered. So, yeah, absolutely, key areas.
So when we take a look at the trends, when we take a look at where organizations are on trying to, realign their margins and their profitability, finance leaders are really asking some real important questions. One, it's what impact does revenue cycle have on our financial recovery? We know our revenue cycle is not performing as optimal as it should. And is there a way that we could get some quick wins by focusing on key areas of the revenue cycle that will really help improve some of our revenue activities? The second question, I think, is a really good one. How do we leverage our denials to inform operational efficiencies in everywhere? So for instance, again, finance leaders understand that they've got high denials in eligibility verification, or maybe they're not creating the pre-certifications like they should. Is there a way that we can use that information to drive performance efficiencies in other areas? The third question, again, is how do we leverage our data to better perform and succeed under value-based contracts? A big area that I think we're going to get into in a little bit is around the risk scoring. It's around HCC capture. Is there a way that we can actually help our physicians do a better job in capturing our HCCs, which definitely helps our value-based contracts, but also has a revenue component to it? And then 4 and 5, again, important. How healthy is the revenue cycle? Is there a barometer that we can use to help gauge where we're at, help identify where we need to go? And then what are the revenue cycle improvements that yield the return? If we're going to invest in this, where do we put our dollars? Many finance leaders do not have any problem spending the money as long as it creates an ROI and as long as it is a pragmatic approach that really drives the results that they're looking for.
Yeah, Dan, that's the area I would say, as you roll through the key areas here, more and more, we're being asked, show me what the return is, show me the performance gap, and if we can close that gap, if we need more resources or technology, help me calculate an ROI. That's just a big one. And just what you said, if the ROI is there, they're willing to move forward, right? So you got to be able to quantify that and clearly, with realistic measures, even when obviously sometimes that's a little challenging with some of these performance gains.
The area that I've always enjoyed about revenue cycle is there's so much information to be gained by the data. And a lot of times as folks are looking at the data, they're not really thinking beyond let's say the back-end collection process, and not really thinking about how that data could really evolve into informational insights that can be used in, say, the front-end operations, or for contracting purposes, or to reduce costs, or to ensure that you have the right level of staffing. And I think as we go through our discussion today, I'm particularly excited about what we can share with the audience on how this data can really evolve into strong informational insights.
Yeah. So with that, Dan, let's go ahead and ask everybody to do a poll. Oh, wait, no, we've got a little cartoon here first.
Yeah, and this just kind of highlights exactly what we were saying. You know, many folks know that they have a problem. They're just really not sure where it starts. But if we're able, through some of the actionable insights, to be able to show, you know, how bad is our cash flow problem, right? Where is our first dollar of profit? And we can create the path to help them improve. Boy, the opportunities are endless. I think just getting that information to folks is really the first step. So go ahead, why don't you jump into the poll?
Yeah, so let's go right in here. I'm going to launch out the poll.
So what are the top issues you are struggling with to improve your revenue cycle? Is it managing denials? Is it evaluating the reimbursement, the appropriateness of the reimbursement, your collections against what's in your contracts? Maybe it's linking the front-end revenue cycle with the back end. And this tends to be a pretty big area for many organizations. Or is it the ability to obtain focused metrics? So in other words, you know that you're at least performing and maybe performing well, but have you ever really compared yourself to other similar practices to really create a bit of a scorecard so you know how well you're doing, or maybe how well you're not doing? Or is it none of the above? Are there other issues like staffing and so on and so forth? So if we could ask folks to go ahead and vote on one of those, I think we'll weave that into some of our conversation. It'll be interesting to see where people are at. And as I mentioned, Russell, a lot of times folks know that they have an issue within their revenue cycle. I think everybody feels like if I was to ask 10 people, 10 of those people would say, yes, we believe we can improve in our revenue cycle. A lot of times they're really not sure where they can improve or where to start. And oftentimes when we work with organizations, we talk about the low-hanging fruit. We talk about the ability to provide a path, to connect that path within some type of an ROI. You have to have the data and the information that translates well into operations and translates well in a way that folks could understand how they can make that change, where they start, where they end, and be able to measure their progress. So those are really a lot of the key things that we see as we start to work with a lot of revenue cycle and areas of revenue cycle. So it looks like we might have some results coming up.
Yep, I just shared the poll there. You should be able to see it on your screen.
Yes, very interesting. Very interesting. I'm not surprised managing denials is number one, but look at number two, the ability to obtain focused metrics, and either to have those key performance indicators for your organization to evaluate it, or maybe even to compare that against other industry metrics. Any other thoughts come to mind, Russell?
No, I was happy to see that not too many people said none of the above, but certainly I'm also not surprised, you know, managing denials, hopefully that's why everybody came here, was that we could help educate them and give them some insight into some things. So with that, why don't we launch right into talking about these 5 best practices to leverage analytics. And so what we're going to cover today, we're going to talk about having a solid front-end revenue cycle, of course, then an effective back-end to the revenue cycle, the importance of accurate documentation and coding, and strong capabilities to support value-based contracts. And then my favorite, number 5, insightful dashboards with meaningful key performance indicators. So why don't we dig right in, Dan, and why don't you launch us out on number 1?
Yeah, so it's important to really have a strong front-end processes as part of the revenue cycle. Frankly, that's where it all starts. It starts with capturing accurate demographic information of your patients, verifying and validating that information, particularly the insurance information, hopefully in some type of an electronic processing format. Insurance eligibility is typically one of the #1 issues that face a lot of organizations, certainly on the front end. And that and probably pre-authorizations can make the biggest impact to your revenue cycle. And interestingly enough, front end folks, the registration people, the patient care representatives that sit at the front desk, they are extremely busy. They may see 30, 40, 50 patients a day, and their primary goal is taking care of the patients when they check in. A lot of these areas of patient eligibility or obtaining the patient demographics, insurance eligibility, capturing the pre-authorizations, sometimes they'll slip by. So, and it has such a large trickle-down effect as you think about how it impacts the revenue cycle. And now it even becomes more important because without that information, we're not able to accurately obtain what the patient's financial responsibility is. So it affects the compliance related to the recently passed No Surprise Act. So there is a number of issues there related to the front end processes that if we're able to really improve that, it can help organizations dramatically as they start to think about their revenue enhancement opportunities.
Yeah, and from an analytics side, obviously, having some good KPIs on insurance eligibility. In some cases, we may need the back-end denials to understand what's going on in the front end. In other cases, we may be able to capture some of those things. As far as the pre-claim edits, this is an area too where you really do want to have robust analytics to get down to root causes. In some cases, we've seen organizations where they're actually self-sabotaging themselves. Things might be getting stopped for no reason, and then there are delays in payment, which could affect cash flow. Or possibly even we've seen organizations where they're writing off claims because of timely filing and they just didn't get them through. So some of their own systems can sometimes be sabotaging their own efforts. So some key reporting areas there, obviously making sure that you can analyze, slice and dice through that data and drill is kind of essential to that front-end revenue cycle.
So when you think about then the front-end part of the revenue cycle, it's only as effective as how well you actually collect and process a lot of the activities on the back end. So the integration of the front end and the back end becomes really important. We saw in our poll that that is an area of concern, and it's more of a concern related to how you use that information. So denial management is definitely a term. It's been a sort of a programmatic approach that we've had in place for obviously a number of years. But when you really dive into what denial management is, it's the ability to identify rejections or challenges with your ability to collect efficiently and being able to take that to the root cause to solve the problem, as well as then being able to fix then that rejected claim so you can get paid as quickly as you can. Denials and a lot of the rejection activities affects compensation dramatically. And we do a lot of work with physicians, organizations on their physician compensation models. Most models today are still around RVUs, and they pay physicians straight on RVUs. So if the patient sees a patient, they enter the charge into the system, an RVU is generated, and from the physician standpoint, they're getting paid for that service, regardless of how it's collected. So if you have a 10%, a 15%, a 20% rejection rate or denial rate on that claim, you're actually paying the physicians more than you are collecting. And it is a real problem. And as I mentioned, if you don't have a strong back-end process that integrates with the front end, it affects your patient collection process. It affects certainly your patient satisfaction because they're not quite understanding. The layperson doesn't understand why you're actually not able to collect on this. The only thing they know is they have insurance. You should be able to get it from them. And then using that information to provide education, I think is really key.
So let's look at a couple areas of denials in particular. Obviously, analytics plays a key role in that, and then we'll touch on physician compensation. So the first thing I'd like to share, most billing systems, they look at what I call the common perspective of denials. This is important from an operational side. And so what I'm trying to illustrate here on the screen is if you look at what was posted in January, we had a bunch of payments posted in January, and we had a bunch of denials posted in January. So we just look by month, what happened in February, denials, March denials. The problem with this perspective, this is really good because if we're working denials in March, hey, we've got, in my example here, 6 denials, right? But if you look at that, the challenge with this perspective of denials, it works for operations. It doesn't work for leadership or management to really understand what's going on in the organization. So a strong analytics team can restructure your data. And so what we're going to do now is we're going to look at January's billings, but we're going to put the payments and the denials into January if they were billed out in January. So we're now matching the denials back to the original period. And so when you take the same data structure in our simple example here, you can see that when we look at this, what we call a matched denial rate, you'll actually see that our denials are going down. We're doing better from an operational side. And so this is one of the key perspectives to the staging that I'm going to show you. I like to kind of set this up. So I want to show you some of the more advanced things we're going to show on the screen. That's one area. The second area is by matching then what we build to what we collected or what was rejected, we can start to understand then, were we able to recover the denials? So what this allows us to do is we can look in June and we can say for what we billed in January, how much of what was denied, 15% of our denials occurred, off of our charges, but we actually collected 7% of them back. So we can measure an effective net denial rate or uncollectible rate. And so those two perspectives I'd like to share. Now I'm going to show you a visualization. This is one of the more advanced visualizations around denials management that we have here in PDS, but let me walk you through it. So first, we're looking at things like denied charges. This is an interactive visualization, so we can see gastroenterology has a fair amount of denied charges. We can start to see across our payer categories. We can even dig down into the payers themselves and start to see where we're seeing the most denials. Okay, we've categorized the procedures into categories. So if we just want to look at the E&M codes that gastroenterology is having trouble with, and we've also categorized our denials themselves, where we've taken out informational denials, and then using that matched perspective of denials, we're actually looking across the procedures. So these are the denied procedures, and then this is the recovery rate. So you can see these procedures here, we're recovering fairly well when we get a denial, but these high volume procedures right here, if I just highlight them, it shows that we're rarely recovering. And you can see it's with Blue Shield, and it's really around surgical and E&M codes. Okay. Now across the bottom of the screen, and this is where we get into quantifying an ROI or understanding what some of the cost is to this denials. We're looking at the procedures. We've assigned it administrative costs to start to understand the impact of denials just on our staff time. We're looking at the charges, but then we brought in the profile amount. So by linking in our payer contracts with the denied charge amount, we can actually start to understand what's the recoverable amount based on that reimbursement. And then if we sort of roll it all the way across, you'll notice they have a very simple switch over here. If the claims are fully adjudicated, you'll notice this column says loss or at risk. That's actually how much we lost because we didn't recover those denials. Or if I had to flip over and click on the no, that's our at-risk dollars. So when we start to think about what hasn't been recovered, where we're having challenges, what's the ROI, this alone might be some of the areas to say, first off, we need to understand where the root causes are. We need to be able to slice and dice and understand the actual details. But to go further, we can actually quantify maybe we do need more resources on recovery, or maybe we need to bring in a consulting firm and help us fix some of the operational challenges where maybe we're self-sabotaging what we're doing.
Well, I'll tell you, Russell, I love this. And the other big benefit of seeing this level of information is it helps the managed care contracting folks as well, too. If you're able to see a trend of the denied claims, and as you mentioned, gastroenterology for one, if you have inappropriate denied claims and you can track those over a period of time, you can weave that into your contract discussions, which really helps then your collectability. And let's face it, at the end of the day, it all comes down to how quickly you're able to collect on those claims and get the cash in the door.
Yeah. Just critical. And that really goes back to, by looking at your recovery rates on procedures, you can start to go back to the payer, as you mentioned, and say, why are you always denying these claims? You're making more work for us. You're making more work for yourself. And yet 80% of the time you're reimbursing us. Let's fix that. That becomes real.
And we've had clients who we've utilized data, you know, and have really done it ourselves to try to gather that information, incorporate it into our contracting. But if you have the ability to really evaluate the adjudicated claims and really turn that in, that's the actionable insights that make a difference.
Yeah. Very powerful. One of the other things I wanted to talk about, we talked about the impact on physicians and physician comp with denials. And so what you're looking at here is a visualization. It's a sample physician comp plan. And if you look over here, you'll see the plan components, 90% is based on RVU production. Pretty common. RVUs tend to be the majority of how physicians are comped. We've also then got some clinic goals and an incentive pool. So, you know, best practice might be to look at patient SAT scores or have some kind of a quality score. You know, we found even a small component of, you know, anything related to patient experience or quality just helps remind the physician that it's not just about production. And then, of course, we even have a team score incentive pool in this mock plan. But the key point here is obviously if physicians are getting paid on RVUs, and you mentioned this earlier, Dan, if we're seeing a 10 to 20% denial rate and we're compensating physicians on RVUs, we're actually potentially paying and losing money on those areas. You know, with good analytics, you could look at RVUs that are just adjudicated. We could filter out, we don't just want to filter out denied claims, we want to filter out denied non-recoverable, right? So that's the difference. And that goes back to being able to match the payments back to the denial and match the write-offs back to the denial so we can really understand, did we get paid after a denial or didn't we? And then, you know, I'll leave that to you, Dan, and your team to say, what's the right way to compensate, right? And we'll talk a little bit more about focusing reports to different group areas. So at least the physician controllable, you know, root causes, potentially we're going to show you how you could highlight those out to the physicians as well. So.
Well, and at least being able to measure the collected versus collectability of these claims, and then to align that with where the RVU payout is going to be for physician compensation. That's probably, I think, the number one area of frustration for finance leaders. CFOs have no problem paying the physicians in an RVU model as long as they make sure that it aligns with what they're collecting. Where they get upset is if they are paying actually more than what you're able to bring in, then you have a problem.
Yeah. So with that, I think we've got another poll here. Dan, I'll let you read out the poll while I launch it.
Yeah, so for the audience, is your physician compensation reconciled against actual collections or denied claims? Or are you just paying straight RVUs and not even taking that into consideration? So, you know, again, of the answers here, we compensate on RVUs billed, and that's it. So once the claim is generated, the RVU goes in and the physicians get paid. We compensate on collections per RVU, which many organizations are moving towards. That, again, helps the physicians become a little accountable to their process, to the charge capture, to their documentation and coding. We compensate on cash collections, or we compensate on a basis of straight salary. And there's still a number of organizations that do that as well. Or is it other? Maybe you have a different type of compensation model, which is a hybrid and maybe includes a lot more quality than any of the RVU areas there. We are seeing, Russell, more and more organizations moving away from straight RVUs and trying to align with quality, trying to align with performance, and frankly, following the value-based care track. And it just makes sense as organizations are starting to shift their managed care contracts from predominant fee-for-service to more and more a higher percentage of value-based care. The compensation structure of the physicians also has to follow suit. Otherwise, there's a conflict that's occurring because, again, you know, the fee-for-service contract and so forth may be more based on utilization as versus in the performance and the outcomes, which would be included in value-based care. How does our results look? Any results coming in?
Look pretty good. Yeah, we've got about 50% voted. I'm going to go ahead and close the poll, though. We got just a couple more coming in. I'll give you another 5 seconds there if you want to vote in on that. All right, here we go. Let's see what we got.
Good. So look at that. We compensate on RVUs billed. I'm not surprised that that's the case because many organizations are still at that 100% RVU or 95% RVU with 5% quality. But look at number 2. We compensate on cash collections. What do you think about that?
Yeah, it's interesting with the changes that Medicare put in place with the E&M codes last year. We had a lot of organizations that were focused on RVUs. We had to recalculate RVUs and even create multiple sets of RVUs so they could use them for benchmarking purposes, but then also use them for reimbursement purposes. And one of our larger private medical groups said, we still do it the old-fashioned way. I'm glad we don't have that problem. We compensate on cash, which I found interesting. So I guess not a complete surprise. I don't know the panel of our audience though, and I wouldn't be surprised if some of the still physician-owned private practices using that more traditional cash collections.
Yeah, I think you're right for the independent practices. Certainly, they're on more of a quote unquote eat what you kill model, which would be really based on cash collections, and frankly, that drives the performance of an independent medical group. So you really have to. For the employed groups, I think it would be more RVU. So yeah, interesting outcomes.
Yeah, interesting results there. All right, let's move on to number 3. We'll talk about accurate documentation and coding.
Yeah, again, another big area of the revenue cycle, and all of these really do fit together. We do a lot of work with organizations on their surgical process, on the perioperative process, being able to really connect that and really connecting pre-authorizations with the right level of coding, with charge capture, and with any of the procedure chains. And any folks that are in revenue cycle or certainly on the front end that work in surgery, they understand that this is an issue. And it's an issue with the plans, in some cases more so than with the practices. When a surgeon, when a patient is a candidate for a surgery, you have to identify the code and put through a pre-authorization. And a lot of times you only have 3 days to update that. And again, making sure that you're providing the right level of information to the plan so you can get paid. The other issue that we see too is the physician side usually goes through pre-authorization, and then the hospital goes through pre-authorization, and sometimes those two areas don't talk to one another. So again, creates another big area of denials. Documentation requirements under evaluation and management, the E&M codes, you mentioned that. That's really important. What we often see is that physicians typically undercode, and by having the right level of information and help them to make sure that they're documenting appropriately certainly helps the revenue cycle. And then lastly, and I'm a huge proponent of this, your documentation and coding has to support your HCC capture. That is becoming more and more important in today's environment, especially as we're moving into value-based care. And I know, as you've mentioned, not only does it help value-based care, but it's the right thing to do with patients, and it does help your revenue.
Yeah, this is an area that I need to speak to from an analytics side. It's probably one of the fastest, I don't know, probably one of the most popular, how can I say that, top popular analytics topics at PDS is HCCs and calculating scores. And even for fee-for-service organizations, as we're going to look at, it has a huge impact on revenue and quality. So it's a key area there. We strongly believe organizations, they need to be able to take their own visit data, and I'll explain why they have to do it from their visit data, not from their EHR, and stage and model that data so they can calculate what were the HCCs per encounter. They also then need to be able to look up and roll them up to the patient. What are the HCCs that we're seeing on the patients? What are we treating? What are we tracking? And how do those scores compare year to year? So we can look and see, are we missing gaps potentially that we had diagnosed in prior years? And of course, if we're not tracking and managing to that, what do you think the insurance companies are doing? Of course, they're tracking and managing to that, and ultimately that's has an impact on value-based payments, but even just on quality incentives, right? So critical that you can measure through and have your own data that you can actively manage with daily and weekly. You can't wait for that payer data to come back to tell you if you did or didn't meet up to their expectations.
Yeah, that's such a great point. You have to be proactive. And as you said, more and more of these contracts are built around a risk component, such as the RAF score, right? The risk adjustment factor score. All that is driven from the HCC. And if you're not able to really capture that and focus on the visit activities, you're going to be reacting to what the payer gives you as opposed to proactively managing it with your providers.
So with that, that's the subject of our next poll here. I'll bring that up on the screen. How does your organization reconcile risk scores? Are you calculating them internally to compare with the payer, or are you just relying on the payer data? So if you want to take a minute and vote in on that one.
So as I mentioned, Russell, we're seeing a lot of Medicare Advantage contracts and even some of the commercial contracts which are using the RAF score. And again, the RAF score does measure the risk acuity of the population, but it also feeds directly into the cost of care targets. The predominant way of calculating that is around your HCCs. So if you're not capturing your HCCs, it's really limiting. You're sort of doing yourself a disservice because you're not accurately capturing the acuity of your patient panels.
Yeah. And not only that, from a financial side, right? You're not providing quality of care, but there's also financial opportunity just in terms of treating those patients, whether you're fee for service or in a managed care. So, all right, I'm going to close the poll here just in the interest of time. We'll share up the results.
Yeah, I'm not surprised it's unsure as the highest level there because, again, if we were talking to more of the managed care folks, they would probably say, hey, we need to do this. We're not sure how we need to do it from revenue cycle. It's an area of revenue cycle. It's a continued growing focus of revenue cycle. But as we've talked about, being able to use the data and the information to connect the dots is certainly a challenge for many organizations.
Yeah, Dan, that's probably the biggest thing that I see is I talk about HCCs and the financial impact and the need for data. And oftentimes I hear, well, that's the medical director, right? So there does seem to be more of awareness today, but in the past, the response was, oh, that's a clinical measure. We don't get involved in that. And it's a very strong revenue cycle metric as we're even going to talk about on the next slide coming up here. So let me hide the poll and let's dig into number 4.
Good. So another key area of denial management is really its influence on value-based contracts. And when we do a lot of work, Russell, with helping organizations not only negotiate the contracts, but then to reconcile and to help them put forth sort of an optimization improvement plan on how they can better perform under these contracts. And one of the first things we look at is what's the denial rate. And if you have a denial rate of, say, 10%, that means 10% of your patients, because they're denied claims, are not included in the calculation. And even though you're seeing those patients, even though you're treating those patients, even though you're doing a good job of managing the care of those patients, it's not included. And it does affect your cost of care target. It does affect your ability to generate your savings. Information systems sometimes are really challenged in being able to provide that right level of information. And the biggest thing that we see is it's not that the data is not there, it's that they haven't turned the data into usable information. So when they present it to physicians, physicians don't understand it. Physicians don't understand, don't really get how it translates to their practice, so they don't know what to do with it. I think that's one of the biggest areas that we see in support of, or the lack thereof, in value-based care and the alignment of revenue cycle.
Yeah, without a doubt. And we'll talk more about getting information out in bullet number 5, right? Getting the right information in the hands of the right people so they have that actionable information. I made this point just a minute ago, but I'll share the slides because I always thinking ahead here. But I mentioned a lot of people assume that what's in our EHR is what's going out to the insurance company, and that's how they're calculating our risk scores. And of course, when you step back and you think about it, it doesn't work that way. And if you've ever really followed the paper trail through, you would understand this. And one of the biggest things is, right, the EHR then, so the physician sees the patient and put it into the EHR, then it's got to go over to coding. That's one step. Coding's got to translate that information, then it gets over to billing. It might hit some charge edits and get stopped there, and billing's got to either translate that information to make sure it gets out. And then we've seen this issue in data, where data is then packaged up and sent to the clearinghouse, which might be bundling your claims data with other organizations' claims data. We've got these computers passing information, and we've actually seen claims clearance houses truncating diagnosis codes right? Which goes back to, so if you didn't bill it correctly, the coding didn't get it correct, it might have gone to the clearinghouse, there's 4, 5, 6 fail points. It goes over to the insurance company who's adjudicating your claims, but that department is usually a different department than the people that are actually calculating your risk scores, looking at the patients, looking at the other pieces. So it really goes to what we were sharing earlier, that if you don't have the ability to take what the insurance company is sending back and measure up against what you know you're doing internally, and in this case, if you are getting denied claims, you know, that gap, right? We go back to that performance measurement. How do we quantify that performance? We've seen organizations comparing what the insurance company is saying they did to what their own data says they did. And of course, you can then negotiate, argue, resubmit. It's a bit of a hassle. Better you get it clean the first time. But, you know, we've seen organizations where this is 6 and 7 figures difference in that 10 or 20%, which often can relate to denied claims or missed diagnoses codes. So,
well, and you're absolutely right. And it is such a lost opportunity for health systems and for provider organizations. And the thing that really kills me about a lot of this is these hospitals and health systems have the data. They have the information. In most cases, they have much better information than the payer does. But they don't know how to use it. They don't know how to translate that in a way where they can actually present it back to the payer to say, look, this is what we've actually done, and this is why it's occurred. And without that, you're sort of beholden to the payer to give you that information. And their data, as we've talked about, their information is not always the source of truth.
Yeah, there's no incentive for the payer to go the extra mile to make sure they got all your data correctly, right?
Yeah, that's true.
Which we knew. The other thing you mentioned in some of your key points here was being able to look at your revenue and look at your expenses and understand whether it's value-based contract, but we're a big believer in, you know, being able to analyze your expense data against your revenue data, and whether it's doing comparisons to understand your operating margins or have a way to look at costing, or in some cases it's very hard to directly attribute costs, you know, because you have direct and indirect expenses. But also being able to look at your value-based contracts or look at the alternative. What would we have collected in fee-for-service revenue on an RVU basis versus how we're being reimbursed through our fee-for-service contract? So having that data also available. You know, Dan, to your point, a lot of organizations have the data, but they don't know how to align it or make it effective so that they can both manage on it and then distribute it appropriately.
These 4 statistics that you have on here are really good. And, you know, kind of getting back to our first poll, one of the challenges that was highlighted was that we don't have good metrics, right? We're not really sure what the metrics are or how to, you know, what the metrics should be. These are great metrics as we look at what the RVU, the revenue is per RVU, and then the salary expense per RVU. It gives you a way to be able to benchmark your practice so it can show you where you either are or are not performing effectively.
Yeah. So we're going to move on to number 5 here. We've got just one more section here, and then we will take questions. We've got a couple people have already chatted in questions. Do feel free to chat in your questions. We're going to take questions at the end of the webinar here. So let's jump into number 5, Dan, and talk about insightful dashboards, kind of my favorite topic. But what's important here? What do you see?
Mine as well. You know, without good data, without good information, it's hard for you to understand how you can change processes. It's hard for you to even understand where to start if you don't have that level of information. You have to be able to leverage analytics to improve performance. And not only does it help you understand where to start, but if you do it right, you're able to create key performance indicators that translate into areas of accountability. It also gives some great feedback to the team on where they're performing well, where they need to improve, and if you put in some process improvement initiatives, is it actually working, right? That feedback tool is really key. The other thing is that we had talked about this in different areas of the organization, different roles, different leadership positions of the organization. Those leaders need to look at different levels of information. So the CFO will look at different indicators than, say, the person who's managing your coding denials. Your dashboards have to speak to your stakeholders in a way that helps them understand how they can make sense of the data and of the information and how it can translate into some level of performance. And I often say, if the information you give them is not actionable, if they don't understand how they could actually impact it, then you have to ask yourself, is it really good information? The last piece is really the key performance indicators. If you have good KPIs that really translate into operations, it not only helps you evaluate your business, but it helps you understand where your opportunities are. So when we think about HCC recapture as an example, if you're able to understand where you are now with an indicator and where you need to go, not only does that help you understand what your revenue opportunities are, it will translate into your RAV score. It'll translate into some of your performance on your managed care contract. There's a whole host of opportunities there. Other things that you have here highlighted, obviously the annual wellness visit, encounter rate, and there's a whole host of others, right? Your back-end denial rate, your eligibility verification statistics, so on and so forth. So I guess the big takeaway for me on this slide, Russell, is that we need to create dashboards that really speak to the audience and translate well into some level of action.
Yeah, and I think this overall really goes to what I call a data-driven, organization culture, right? Trying to use data to drive performance improvement. So just a couple examples to sort of share what we talk about. We like to say here, making sure the right people have the right information at the right time, right? That's really what it's about. And so as an example, we talked about physician controllable denials. We don't just want to show physicians' denial rates. As a matter of fact, most of the times when I've been in the room when physicians start to see denial rates, they get really mad. They think, I'm doing all this work and you're not collecting the money, right? So our ability to take and pare down what are the denials that are potentially controllable, where we could then recategorize that. And to your point, Dan, just showing physicians what they need to see that they might have an impact on, right? And so as an example, being able to put that into their, daily or monthly scorecard they might get back as a trend indicator. How are you doing against that, as one example?
Well, and I think it also, if you should be presenting rejection and denial information to physicians in a way that they understand how they can impact it. Because many times when I presented information, and I'm sure you have as well too, physicians come back and say, well, look, that's not my problem. I don't collect it. That's the billing office's problem. Well, that's true, but they can certainly influence some key areas of the rejection or the denial in order to lessen the problem. That's the information you have to present to them.
And then just, a couple other quick examples, because I want to make sure we have time for questions. You mentioned having good wellness visit analytics. And so here's an example of a dashboard very focused to understanding, management. We might just filter out who are our high and moderate risk patients based on their HCC scores that we're calculating. We could then join in our scheduling data to understand who has upcoming appointments, who's past due for their wellness visits. And then we've sorted the physicians so we can start to say who's past due on their wellness visits or maybe never had one, and who has no upcoming appointment scheduled that we can't even talk to them about scheduling that, right? And so right away now we can filter right through and say, well, who are these top physicians within this department? Maybe we need to get some care teams focused or outbound calling and making sure that we're scheduling and taking care of these patients. It's a quality issue. It's a financial issue, just as an example. So the right analytics, being able to understand where's the gaps and how do we close those gaps, and certainly close them before the year ends and we can't get those wellness visits in. There's a host of issues there.
Yeah. Well, you're absolutely right. And like I said, any of that information that you begin to present and how you slice it, it has to be meaningful to the providers. And I think if you can do that, then all of a sudden you start to change the culture of the organization. You make yourself, and I love your term, Russell, a more of a data-driven organization, but it's really data-driven around actionable insights.
Yeah. And then to sort of tie together some of the things that we talked about at the beginning of the webinar, which is understanding the ROI, right? And we've seen organizations, we had one group that really ran with this type of reporting, which is, let's look at a particular department and let's understand who's using wellness visits. You can see we've got some physicians here up in this 50, 60%, right? And then we have other physicians down at 10%, right? And the last couple statistics, Dan, you may know more than this, but the average utilization of wellness visits was still like less than 20%, the last data sets that I saw. And so in either case, what we're trying to do here is to quantify the physician opportunity improvement. And so if we look at, say, these bottom physicians here, you can see the average improvement across the data sets. And we can start to understand, what is their performance improvement? What if everybody just improved 15%, or what if they improved 140, to the department average? What might they impact on the organization there?
Yeah, so wellness exams that's a big one, because not only it certainly has a major impact on your revenue, but it's the right thing to do with patients because you're able to validate their diagnosis codes and so forth, and then it translates directly into your ATC capture. It almost becomes a requirement of a lot of the commercial ACOs if you're really going to perform well on your value-based care contracts and so forth. So there's a whole host of reasons as to why it would work. And even from a cost and efficiency standpoint, if practices can incorporate, say, the nurse practitioner into the process of annual wellness, not only are you increasing your revenue opportunities, but you're doing it in a way that creates a lot of efficiencies for the practice.
Yeah. So with that, let's jump over here. I think try to get over to some questions. We've talked about a number of different points here. We've got a couple questions that came in. I've got one in here. Any ideas on how to create incentives for physicians that might help reduce denials or impact the time to payment?
Yeah, that's a good one. So, well, I'll share how we've done this with other organizations. We've actually looked at the rejections that come in, and you're looking at those from your response codes, from the claims that are being passed through, and you segregate just those rejections that the physicians can begin to influence. And in some cases, what we've actually done is, depending upon how large the problem is, and you can quantify that, right, by the total dollar amount of what that denied claim target is over a period of time. If you're able to reduce it by, say, 2% or 3% or 5%, we've created some of those dollars and actually offered sort of a shared savings opportunity for physicians. So it's been an added opportunity for them within their contract. That's one way of being able to do it. The other way, which is a little bit longer, is kind of changing the compensation model. So you're tying some of that performance into their compensation. But the first one is better. The more that you can engage them into helping to solve the problem, working with their teams, working with the patients, and physicians absolutely want to do the right thing. And a lot of times, if you're able to share this information with them, just through the Hawthorne effect, making them aware of what's occurring, you're going to see some improvements.
Yeah. We've got another question. One I think is a comment, but one question is, would you suggest all physicians use HCCs regardless of the insurance?
I would, because I think it's good practice. And we're seeing the growing trend into HCC capture and into the RAF score. And as an example, I'm not sure where the audience is at, but Anthem is changing a lot of their risk calculation to RAF scores. So we are seeing that as a continued growing trend. We're seeing more and more of the commercial payers moving away from their own proprietary risk scoring and into RAF scoring. So if you're going to do that, HCCs become an important component. Plus, as we've highlighted time and time again, it's the right thing to do for the patients, it's the right thing to do for the practice, and there are revenue opportunities there.
And the same person there wrote, very hard to handle pre-claim edits with most insurers automatically denying modifier 25.
Yeah, that's a killer. That is a killer. And I guess I would offer two suggestions. I think, one, you have to make sure that you have to put through the pre-authorization. You want to make sure that you have a process in place to quickly correct that after the surgical services is done. And if there are any changes to the documentation that has to be coded or the modifiers, you want to do that as soon as possible. The other thing that I would do is I would advise your managed care department, because that should be, if that is an ongoing trend with your commercial carriers, weave that into your contract negotiations. We are seeing payers willing to reduce some of those administrative challenges. but you don't get it without asking, you don't get it without discussing it, and you certainly don't get it without presenting the right level of information.
Certainly, if you're interested in learning more about Lumina Health Partners and the different services they offer, please feel free to reach out to them or visit their website. And same thing on our end, if you're interested to learn more about PDS or analytics and reporting, please feel free to reach out to us either directly. Both Dan and my email is on the screen here, as well as through any of the contact information. We certainly appreciate you joining us today, Dan. I really enjoy presenting with you. It's been a while we've done this, but it's certainly been a pleasure. So thank you for agreeing to be part of this and pulling it together. And
well, likewise, Russell. Really appreciate your invitation, and happy to do this with you again. It's fun.
Yeah, thank you. And then all of you who attended, thank you so much for joining us today and your interest in the topic. And we certainly hope to see you at either some of our upcoming events. Dan's got a regular podcast he does, and we've already started planning our April webinar topic. So we hope to see you coming up at future events. So, all right. Thank you so much for joining us. Have a great day, everyone. Appreciate it.